in your abstract, you highlighted that there's an overemphasis on protecting against false positives while neglecting false negatives. So, can you briefly explain what that trade-off means and why it is damaging for patients and caregivers waiting for the new treatments to come out?
Well, let me just start by talking about the evidence that we have overprotected our type 1 error, our false positives. So the evidence for that, first of all, is that 20-year gap we talked about earlier. That's part of the evidence anyway, because with what was in a few different sources cited as a 99.7% failure rate in Alzheimer's disease studies. One thing that we sometimes say is that we are owed some type 1 error. I mean, if we're using a 0.05 alpha, then we should have a 2.5% type 1 error on these studies. And the failure rate, even if they were all bad, would be 97.5. But I happen to know that they haven't all been bad. And so our failure rate should be something below 97.5%, and it definitely hasn't been. So that's some evidence of the type 1 error. One of the causes of that type 1 error that we've seen, and maybe more evidence that regulators are maybe a little too concerned in protecting against false positives, is the fact that we have been and still are encouraged in some settings to use co-primary endpoints. Just by their nature, a co-primary endpoint that is not between two endpoints that are perfectly correlated is going to overprotect type 1 error. It's going to discourage false positives in a way that is too conservative, that is going to cause good treatments to fail, it just by design. So we should not be using things that increase our type 1 error or decrease our type 1 error to a point that is below what has traditionally been accepted by regulators. So that 0.05, which is a 0.025 type 1 error rate for treatments that are not effective. But that affects your false negatives. So it causes us to increase our false negative rate. Therefore, we're not protecting the population from bad treatments at this point. We're protecting them from good treatments. And we should be doing everything that is necessary to get good treatments to patients. And anything that we're doing that prevents a good treatment from getting to a patient is by definition hurting the population. And we just haven't been focused on that enough. So one of the changes that I would advocate is if regulators could look more at risk-benefit analysis as they're evaluating drugs. For instance, if you have a very clean safety profile, the bar for approving that treatment should be lower than something that has a high has a high safety signal. And therefore we can push these things out, and by getting treatments to market, or in other words, by getting treatments to patients, we can start finding the things that work through larger phase 4 studies and just through post-marketing studies in general. Sometimes with these complex and difficult diseases, we need to get to a solution through iteration and not through one giant home run. I don't know. I believe that a solution to Alzheimer's disease isn't going to come through one home run. It's going to come through the iterative process of getting more and more effective treatments to market.